equity in health and addressing health disparities tend to be abstract. How then do we bring equity into the discussion of the processes of history taking, physical diagnosis, clinical management, and prevention? In this session, we will be asking experienced physicians to discuss their approach to equitable healthcare in relation to concrete cases. The aims of this session are to highlight one, social and cultural understanding and patient perspectives of their illness, two, clinical approach to cost effective management, and three, how to apply evidence at the bedside to ensure equitable care. With that said, I now invite our moderators, Dr. Venkatesh S. and Dr. Dorothy Lall, to moderate the session. I now invite Dr. Bobby Hudson, a final year postgraduate student, MD General Medicine, to present the case.
Good morning, everyone. Today's discussion is about the health equity, and I'm going to discuss a clinico-social case of one of our patients who presented to CMC below. Regarding our patient is Mr. A, who's a 63-year-old male from KV Kuppam, which is 25 kilometers from CMC, and he's been a resident of that area for the past 10 years. He's married, and his current occupation is a daily wage laborer, but earlier he used to work as a bus driver, and he belonged to the class of washerman according to the social group. His presenting complaints when he presented to us in the month of August was cough with expectoration for the past 3 days, but the expectoration was very scanty and breathlessness at rest for 1 day. Coming to the history of present illness, our patient was already known to have episodes of breathlessness with wheeze for the last 10 years, which was insidious in onset and which was gradually progressive. It was associated with cough, which was scanty and had a mucoid in nature. Initial few years, he was able to perform all his duties, daily activities with minimal symptoms, which were more in aggravating in nature on exposure to cold, dust, pollen, and more in the winter seasons. However, over the years, it gradually progressed that even in between the episodes of worsening, he couldn't do any moderate work that he was able to do earlier, which was limiting his daily activity. When he presented in the month of August, because of these symptoms, he didn't have any fever or purulent sputum. He didn't have any hemoptysis, orthopnea, or any chest pain. Nor did he complain any loss of weight or appetite in the past 10 years also. So he was initiated treatment for further during the current episode, and he became better. Coming to the socio-economic history of this patient, coming to the family details, number of family members included only two, the husband and the wife, and the type of the family was a nuclear. The emergency contact in case of any health issues or any other activities for the current family is the patient's brother who was residing near Gudiyatham, which is again 20 kilometers from his current location. Mr. A was the head of the family and daily laborer. His education standard include only the primary education up to 5th standard, and his income per month was 2,500. His wife also used to help him as a daily laborer, but not every day. She goes only work for 3 days in a week, and her income per month was 1,000. With no health comorbidities for the wife, but the patient is already diagnosed as having as COPD 1 year ago, and he's also having other comorbidities like diabetes mellitus with a query past history of coronary artery disease. Coming according to the modified Kuppaswamy classification, they come under the upper lower class of the socioeconomic status, but they're financially independent without any debts or coming to the monthly expenditure of the current family, their expenses, most expenses were on the medical needs. It is consisting of about 57% of the family income. And as you can see, the electricity bill is only 200 rupees and the LPG is 900. There's no debts. Coming to the food habits of the family, he's a non-vegetarian and the staple diet is rice and with no any dietary restriction. Functional status of the patient, he is able to perform daily activities like bathing, feeding, dressing. He is able to ambulate from bed to chair and he is able to do his own toileting. He goes out for buying vegetables and cycle is used as a mode of transport and he uses a basic mobile phone for communication. Coming to other socio-cultural environment, he interacts with his neighbors who are present in the same street. Most of the time, he spends taking care of his cattle. Coming to the health accessibility for the patient, the nearest hospital for him from his home is RUSA, which is a rural unit for health and social affairs, a unit formed by the CMC Velo. And the other government hospital that is very near to his house is around 5 kilometers from his house. Uh, Coming to the how do this family make use of the healthcare facilities near to their house? They do often used to go to the PHEs, Government Velo Medical College, RUFSA, CMC. They visited all the different hospitals that we have mentioned here. But they couldn't, other than CMC, they couldn't visit any other private clinic because of the affordability issues. And therefore, we cannot comment on the quality and the utilization. Coming to the residential environmental status, the house in which they reside is their own house with 2 rooms. It is a Pakka house. However, the road to the house entrance road pathway is there is no proper pathway. The house consists of only 2 rooms. One entrance has only one door, and the entire house has only one window, which is always closed. Also, the other out of the 2 rooms, one room is the kitchen, where LPG is the source of fuel, and exclusive lavatory was situated outside the house, which is again an initiative from the Tamil Nadu government. As you can see, this window, there's only one window which is always closed, and this is the status of the kitchen that the patient stays. Coming to the water resources for domestic usage is the borewell that is present within the house, and the drinking water is facilitated by the government RO facility, which comes once in a week or twice in a week. Coming to the waste management segregation, it is not segregated properly. It is collected in a plastic bin which is nearby, and the waste is usually dumped in near the house so that they can use it for the manure. However, the unused waste is usually collected by the government or the local resources once a week. Other facilities outside the house, is there in any accident prone area? There's no accident prone area, but the street also consists of the street lights. Stray animals are usually present, the dogs are present nearby, and the house contained an open drain nearby, therefore being a vector breeding site. However, the patient or the family did not come into contact with any TB patients nearby. Coming to the personal history of the patient, he's a non-vegetarian, who had a normal appetite and consumes 3 meals per day, and has done adequate sleep with a normal bowel and bladder. He was a reformed smoker since 8 years. Earlier, he used to uh, smoke 2 packs of BD for the past 40 years. Actually, I can say he started at the age of 7 years smoking, and he was an alcoholic for the past 10 years, reformed alcoholic for the past 10 years. Coming to the past history, as we have discussed again, he was a known diagnosed COPD since 1 year, not 10 years, but the symptoms started since 10 years. Diabetes mellitus since 6 years, and he had recurrent admissions to the hospital for the past few years. Last 2 years, he had more than 2 admissions per year. He is not a known case of hypertension. There's no history of any asthma in the patient nor in the family. There is no past history of any pulmonary tuberculosis. There was no history of any prior surgery or known allergy. And coming to the medication history, he's currently, after the current admission, he was started on MDI inhalers, and he was also on his continuous oral hypoglycemic agents for the diabetes. Coming to the family history, there were no similar complaints in the family history, nor there was any history of tuberculosis, asthma, or any cardiovascular diseases in the family. Coming to the general physical examination, he was conscious and was oriented to time, place, and person, and his vitals were normal with a respiratory rate of 20, and which was abdominothoracic in nature. His BMI was within the normal range. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or not pedal edema. However, he was using his accessory muscles of breathing with a flared align assay and had pursed lip breathing. Coming to the examination of the respiratory system, upper respiratory tract examination was normal, and the lower respiratory tract examination on inspection, he had a barrel-shaped chest and the hollowness in the supraclavicular fossa. However, the same was confirmed with the palpation, and his anteroposterior diameter and the transverse diameter was almost the same, which was 22 centimeters. On percussion, he had a hyperresonant node. On the trough space, there was a hyperresonant node. On auscultation, he had a vestibular breath sounds with minimal wheeze in all the quadrants. Coming to the other system examination, the cardiovascular system was normal with a normal JVP, and both S1 and S2 were heard with no murmurs. Abdominal examination and CNS examination was also normal. Coming to the investigations, when he presented to us in the month of August, the HP was normal, but however, there was an elevated total counts with a differential, with a neutrophilic predominance. And however, other investigation showed hyperinflated lungs, but spirometry was also showed obstructive airway disease pattern. And further tests revealed that he had a grade 2 according to the gold classification COPD. So, based on our history and the investigations and the examination, our medical diagnosis was a chronic obstructive pulmonary disease with an acute exacerbation belonging to the gold E category along with the type 2 diabetes mellitus. But however, if you look at the clinico-social diagnosis, this is a nuclear family belonging to a low social economic class, of which the index case is the current patient, which is a 63-year-old man with COPD and history of diabetes, with family living in adverse factors of inadequate ventilation, vector breathing sites, open cellular system. And if you look at what went wrong in this thing, I would say that both the primary and the secondary level of prevention has failed in our current patient. But before going into further discussion, the current treatment that we gave when he presented to us was he was started on IV in nebulization. NIV was started because he presented with a type 2 respiratory failure. And after adequate blood cultures were taken, he was started on appropriate antibiotics before the blood cultures were awaited, reports were awaited. Slowly, the NIV was tapered, he was changed to MDS. And before discharge, he was vaccinated against pneumococcus and influenza. And his sugars were also controlled at the time of discharge. So the total expenses of the treatment, the hospital bill came around 35,000, but based on the financial status of the patient, 100% concession was given to the patient. However, indirect expenses, there was a loss of income because both the husband and the wife were in the hospital itself for 3 to 5 days, and the transport from their home, which is KV Kuppam to the CMC Vellore. Taking 2 buses, it cost around 30, so around 90 rupees, because every day the wife has to go back in the morning to give milk to the local people. However, the food for the bystanders, which included both the brother and the wife, again costed 300 rupees. Our further discussion, the first question that we wanted to think was, why did this patient develop the disease? Based on the medical diagnosis, if you're thinking of a COPD, we have already excluded bronchial asthma because there was no, the disease symptoms developed after the 40 years of age. Before that, he didn't have any symptoms. So bronchial asthma, he didn't have a history of bronchial asthma. So then we are thinking it's not related to any genetic. Most probably the cause would be an acquired cause. Then why did he develop the disease? For the COPD, as we all know, the most common risk factor is smoking. As I have discussed earlier also, he started smoking at the age of 7 years, which is very much common for most of the children in the rural areas. When I asked him, why did you start smoking at 7 years of age? He said that his father sent him as a cleaner to in a lorry traveler, where the other lorry drivers were smoking BDs, and that's how he picked up the smoking habit. So, like as we all heard yesterday from Dr. Hurst's speech, the causes of the causes. So why did he develop the disease? Smoking. Why did he develop smoking? Because he was denied education and he was sent to as a child labor at the very younger age. Someone developing smoking at a small 7 years of age, I felt very bad. What could have prevented it? First of all, I would say that I don't know how many have you seen properly the children in the rural areas, but this would definitely have a huge impact on the entire individual nature. When you go to any rural areas, the education in that area would definitely play a predominant role. What would have prevented from our health system is, before we discuss all of this, is that education of the family, the parents and the students. Because how an entire family has been destroyed because one person, the head of the family, has was not given a proper education at an appropriate age. This is what I understood from my patient. what would have we been prevented? Proper education to the parents and the children at the right time. And who can contribute it to that? We as a healthcare professionals, not the physicians, may be in the different specialties, but as a healthcare uh, team, we can contribute at multiple levels to educate them at multiple levels. Not only educating the adults, elders, but if you educate the children and adolescents, that would actually bring up a huge difference. So how can we help? Like how we discussed, RUFSA has actually helped this patient realize that the patient has developed the disease because of the smoking. I asked him, "Do you know the cause of the disease that you have developed?" He said he didn't knew initially until last 1 year when he went to RUFSA, where he was explained that the cause of the disease was because of the smoking for the so many years, and he need to quit smoking. That's when he started quitting smoking. So we need to educate at every point of level. Whenever some patient comes to us, it's not only about just treating the patient and giving the medications, but uh, being a physician, we could become a better teacher by explaining him the pathogenesis in a way that they can understand, so that they can go back and educate the others. This is how we help the patient for this in this current scenario. Coming to the what are the social determinants of health that had affected this patient, as I would said, I would definitely put education, access, and the quality as the first thing for this patient. And why was he denied education? Because the family was not getting enough economical strength. So economic stability was the other factor which was again affected. Healthcare access and equality for this patient, I would not say that he was not denied. He was denied of any healthcare access and quality, because at every set up government hospital facilities that were present nearby also, he was getting adequate care, but it was already too late for him. The neighborhood and the building environment and the social and the community context again come into a major role, because as we have discussed, if someone else would have come and told him that why are you smoking, or why are you getting denied of education, if someone would have asked their parents, the current scenario would have been prevented. One more question, that when we asked the patient, like, did anyone ask you to stop smoking? He said that except his wife, no one has ever told him to stop smoking till the patient came to Rusa 1 year ago. So, what is the current attitude of the family members? Yeah, as you know, the patient was well aware of his condition. He knows the cause of the condition currently, and he knows that it may further worsen, and he needs a lifelong treatment for it. Coming to the attitude of the patient, currently they are willing regularly to go to the hospital regularly, and he already quit smoking and alcohol consumption, and he is now currently compliant to his diabetic medications. His current HbA1c is 6.2. Coming to the ideas and the concerns and the expectations of the patient and the family, is they accepted the health status, and their idea, as I have said, is if they would have known a little bit earlier that this is so much harmful, they would have stopped it. And the current concern for this family is the financial burden, because the monthly expenditure is mostly contributed to his medications only. The current What is his expectations? He wanted a much more cost effective healthcare for his current disease. As I have discussed, these are his current problems, the COPD and the diabetes that he had. And his interventions are already, as we can see, he's already on proper medications for the same. What is the psychological problem in this aspect is that the wife is stressed about what will happen to the husband at any time. So the proper counseling need to be given to the wife also, which our social worker and the RUSA team has taken care of. And coming to the other problems in this family is the environmental problem, where the vector breeding sites and the ventilation is not adequate with an open cellar system. So we told them about the proper waste disposal and to keep open the windows so that they can have adequate ventilation. Uh, Coming to the advice, like we already told the patient, we advise patient that a regular health checkup needs to be done, and he need to be compliant to the medications which he is already on. For the family members, as they are coming into the geriatric population, as we can see, the patient's age is 63. So he needs to be aware of the changes related to health. So the entire, if the family members can be educated, like what all changes in a geriatric population they are known to occur, if they can be educated and what can be done to prevent them, that would be a better health education that we can give. So that is also that for that they have to accompany come to the local hospitals regularly, where they can be counseled properly. Also, the repairs and the maintenance of the house were advised, but with some financial assistance. And for the community, as we have discussed, the health education plays a key role. Without that, I think the health system is of no use. Thank you.
Thank you so much, Bobby, for that excellent presentation. Maybe I would invite any questions or any clarifications regarding the case from the audience. Yes, sir.
Could you hear what I said? I said that we have inhalers and all kinds of treatment options in CMC. I know that you're working in a government setup right now. What would you give for a patient who comes to the OPD? So right now, I'm also in a government setup where there is only Derifilin salbutamol tablets, and they come regularly for injections of Dexa Derifilin injection and a nebulization salbutamol. And they, especially in the winter, it's like maybe every other day. So, and an inhaler costs 400 rupees. So how are you, what is the solution? What can I do? Do you have any suggestions?
Yeah, that is very much a practical question. Yeah, 2 days ago also we had the same patient in the government setup that I'm currently posted. I would say that I would refer them to the like places like RUSA or LCSU where the low cost effective care is adequately being given to such patients. Again, depending on the we have to see that mode of the transport and what all economic status of the patient. But before all of these things, I'm just currently giving the health education. I'm just telling them what they need to be done. In case of emergency, come to the casualty, what needs to be done, what are the symptoms that can precipitate, we'll give. But apart from that, what we can tell them is like to prevent the precipitators like exposure to cold weather, put some mask or whatever sheet that they can afford. I would say prevention is better than cure. But we would definitely recommend the adequate treatment, that is MDIs, LAMA and LABA. But with, again, as I said, we'll try to search whatever is the nearest low-cost effective care unit that the patient can go to. We can refer to them. That's
Bobby, what category of gold category he falls into?
He came under gold category E, sir. More than two exacerbations in a year.
Hospitalization also.
Yes.
So category E, what is the recommendation?
They need to be on a lifelong, both long-acting muscarinic agonist and long-acting beta agonist, along with inhaled corticosteroids.
Okay, because his frequent exacerbation,
Yes.
if eosinophil count is more than 300,
Yes.
you will. Okay, so this is the guideline across the world. Just wanted to reply to your question that even the oral bronchodilators and every 2 days of dexamethasone injection and derifilin injection and salbutamol nebulization cost money. It's free in government, but that is somebody in state is paying for it. Actually, if he takes in December alternate days of derifilin dexa injection and a nebulization, it's more expensive than the inhaler. Because we costed the one dose of nebulization given to the patient by a nurse spending 10 minutes cost 120 rupees. Actually, if you give 15 times, it's actually 1,500 rupees. It's 3 times costlier than the inhaler. And I have not worked in government, but I know that it is possible for the medical officer who can stock any medication available locally with the current state health guidelines. So when you become a in charge medical officer, you'll be able to stock inhalers if you want to. Okay, thank you.
Two quick questions and a comment. First one, when did midday meals start in Tamil Nadu?
Sir, how come
Okay,
that is
system,
related?
okay, it is very relevant, but I'll give you the reason. 81, roughly, because when we joined MBBS, it has started. Second question, when did he start having his COPD?
Since 8 years, he's been having his symptoms. Sir.
8 years. It's a
Yes,
bit difficult. But once, in about 10 years' time, when the children who got the benefit of the 81 midday meal came, then this question of education no longer exists. the suggestion of give education doesn't make too much sense because already education is fairly widely spread. Very few children are now doing that type of child labor that we saw even in the 80s. Child labor has come down drastically. We have companies in the mess, 5-year-olds, 6-year-olds eating, working in the men's hostel mess.
Any other question? We can take one more question.
Yeah. Am I audible now?
Yes, yes.
Yeah. Sir, I work in Sevagram Medical Hospital as a second year resident in medicine. And we have many patients who are chronically exposed to different stressors and they have chronic lung diseases and they have to be put on long-term oxygen. So then it becomes a very difficult task for us to explain the need of oxygen in the first place. Second, make them oxygen available at their home at a cost which they can bear. So I would like to hear a CMC experience on this because obviously there are many patients of post TB and even COVID for that matter who are put on oxygen at home. So are there any specific policies you have employed or you have tied up with some private suppliers?
Your question is the indications for long-term
No.
oxygen
Is
therapy.
CMC doing anything different? Like they are making available oxygen for the people in the community, basically because we work with the same community, similar type of socioeconomic background. And then it becomes very difficult for us to explain the need in the first place. Second, to make oxygen available. So we have to contact many people and get an oxygen cylinder because it's very costly.
I don't think the patient whom we are discussing needs long-term oxygen therapy currently. Is that right? You want to answer?
No, he's asking.
Yeah, I think his question is larger to the question of cost. And the question you're asking is a very pertinent question across the board for all kinds of diseases, including COPD. And I don't think there are any easy answers. How does CMC do it? There are many ways in which we sort of subsidize, we give free treatment, we pool money so that we can, make it available to people. But the ultimate answer is universal health coverage. And the government and state has to take responsibility for providing healthcare for most people. And that is the only way and the only answer. And we have to push our governments, we have to demand it to ensure that this sort of happens and materializes in time to come. So that is one. I just wanted to make two other points with, one more question is there. Yeah, sure.
I work in the general medicine department here. What COVID has given us is a large number of oxygen concentrators for as donation and at a cheaper rate. And there are many Indian companies which are now making cheaper oxygen concentrators. From COVID times, we have a stock of this, which we have been giving out to the community for the past 3 years without a charge as long as they have electricity. They're with a charge for patients who can afford it. So that's just an
Thank you so much. So cost considerations, economic and the social determinants of health that he put up, the chart which shows all the various different social determinants is a important consideration. This distinction between clinico-social and having clinical separate is an artificial distinction because every clinical case is a social case and everything is in a context which has implications. So I think one of the first steps and what I think he also brought out well is the need to capture this and the need to extend our histories to also include these. There are some very good tools that are available, and that is a few of which we sort of use in our own clinics. But we have the advantage of having a catchment area and being able to do this. So there are validated tools by which we can assess some of these. And a social diagnosis, especially in the case that we just saw, is catastrophic health expenditure. If you noticed how much he was spending on healthcare, it's more than 10% according to the definition of catastrophic health expenditure. And he's a prime case of somebody who is going to probably face, he will end up in debt one day going at the rate at which he is going. It's a disaster waiting to happen. So making a diagnosis like that also enables us to then be much more careful to maybe in our own communities highlight these people. They are going to need social support. They're going to need help. So that's the way in which this helps. Of course, we cannot do everything as doctors, but we do have help. There is extended social worker and other networks which we can tap into, which we need to, as well as government schemes and services which we can make available to patients. So I think that's what extending our cases to looking at social contexts of people does, and it's something that we need to do on a much larger basis. Yeah.
I want to ask one more question. As a physician, how will you prevent another hospitalization or another exacerbation? So because every hospitalization is expensive, either patient pays or hospital pays. So is it possible to, because COPD is a progressively worsening disease. We are only limiting or slowing down the progression, but preventing hospitalization is something which we have to work on in this patient. I think that's what is going to cost money.
You're asking for this patient alone, sir?
This patient are in general category E patient, you know.
Any
COPD.
patient who's already diagnosed, we just need to first thing I felt was like, we need to make the patient should understand why he developed the disease and what is the pathogenesis, because simply giving the medications and we telling them that this is the treatment, the patient may not be compliant to the treatment. We don't know whether the patient in the home, whether, because to prevent the further exacerbation, he should be compliant to the medications. So he should understand the complications or the repercussions that if he is not compliant to the treatment, he'll definitely end up being hospitalized. So for that, we need to explain the pathogenesis in a way he understands. Maybe we can draw some pictures when he comes to us, when he is diagnosed. And first thing, if we can help the patient to understand in his own knowledge, then I can say we can prevent the most of the hospitalizations. But as the pathogenesis keep going, eventually the patient should understand that this is irreversible thing and he needs a little bit of help. So we can provide some financial assistance for that.
Very quick one. Did you mention what the cooking fuel was in the house?
Yes, sir.
Sorry, what was it? I forgot.
LPGs.
Vaccinations, will it may help to
Yes, sir. Yes, sir.
because there is evidence that it reduces hospitalization.
Yes, sir.
He had vaccination.
He had vaccination. At the time of discharge, we are vaccinated with pneumococcal and influenza vaccine.
Okay.
Bobby, what about regulating advertising and sale of tobacco? We didn't advertise. That is a 7-year-old child having access to BDs and cigarettes. So yesterday we talked about banning the sale of rodenticides in Tamil Nadu. It became a geo. So
I would say we should ban the sale till the 16 years of age, sir. But unfortunately,
So I don't know if he has an answer to it, but thank you so much, sir, for raising that. I also just wanted to, much as we are talking about social determinants of health, this is a commercial determinant of health. So also to think about tobacco, food industry as commercial determinants also of health. And these are things that we do need to combat even as doctors. Like sir was saying in the morning, some of us are going to need to get into policy, advocacy, are going to have to raise our voices against these if we want to see change. If we want to see our young children not being exposed to smoke in the coming years, this is something we will need to do. So being aware of the commercial determinants of health, I think also is extremely important. Thank you, sir, for raising that.
If there are no further questions, shall we close this session? Thank you, Bobby, for that.
I thank the medicine department and the moderators for giving me this opportunity.
Thank you.